Mrs. Bond.
What?
Mrs. Bond, let's leave your catheter alone.
Oh.
Okay. Oh, here, let's put your
I have to go
oxygen
to the
back
bank,
on.
dear.
Okay.
I've got to go.
Okay,
I
let's
have to go
sit
put
back.
my checks
Let's
in.
put your oxygen back on.
I have to go. No. I have to
Thank you
go.
very much.
I have to go to the bank. I got to put my checks in. It's the rule.
Okay.
It's the rule. I
Mrs.
got to
Bond,
go. I have to go.
You are at
now.
the hospital.
No.
You're safe. You're okay.
Am I sick?
Yes, you are.
Oh, no.
Here, let's put your glasses back on.
Oh.
There you go.
One of the major issues when we talk about delirium in the older population is how common it is for us to not even recognize that delirium is there. And there's been, again, study after study that have demonstrated that as nurses, we miss more than 50%, sometimes 60% of delirium cases in the older adult.
In the following two scenarios, you will see two episodes of delirium. One in a patient with no underlying cognitive impairment, and the other in a patient with some signs of memory loss.
Good morning, Mrs. Bond.
What?
Good morning, Mrs. Bond.
Oh, I hear you now.
Can you see me where I'm sitting?
Well, I have trouble with my eyes. I see better on the side than I do out front. Yeah.
Okay. Then I'll say sitting right here.
Oh, okay.
My name's Ashley. I'm going to be your nurse today.
Okay.
Now, can you tell me what brought you into the hospital?
No, not really. I must be sick.
Yes, the doctor thinks that you have a pneumonia, which is an infection in your lungs.
Oh.
Hopefully with a few days of some antibiotics, we'll be able to get you home.
Okay.
Yes. Now, whereabouts do you live?
Well, I live with my daughter and her husband, and they have 3 children. That's where I live.
Good. Now, what are your 3 grandchildren's names?
I'm not too sure.
Now, I just have a few questions to ask you, some routine questions that we ask all of our patients in the hospital.
Mm-hmm.
Sometimes when you come into the hospital, your brain acts a little funny. Now, we just want to ask a few questions to make sure that that's not happening to you. Is that okay?
I suppose so.
Okay. Now, what year is it?
1975.
Okay. Now, do you know where you are right now?
Well, I'm in the hospital. I don't know which one.
Okay. Now, when's your birthday?
Well, I'm not too sure about that. But I know I'm old. I'm old.
Okay. Now, the next thing I'm going to have you do is count backwards from me. If you could, start with 20 and you work your way backwards all the way back to 1.
Okay. 20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10.
Ashley
9,
completes her assessment, and later Mrs. Bond's daughter arrives for a visit with her mother.
Well, the kids are asking about you too.
Oh, are they here with you?
No, they're at school.
Oh,
Good morning.
okay.
Hi.
Hi, how are you?
Good. My name's Heather Evans.
Nice to meet you, Mrs. Evans.
Nice to meet you.
Now, are you Mrs. Bond's daughter?
Yes, she lives with us.
Okay, great. My name is Ashley. I'm her nurse today.
Okay.
Would it be okay if I sat on your bed to ask you guys a few more questions?
Sure.
Okay.
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 Okay, thank you. So, Mrs. Evans, I was asking your mom a few questions this morning. I read in her chart that she does have some vascular dementia. I also noticed that occasionally, Mrs. Bonds, you had some trouble remembering some things. Right?
What?
This morning when I asked you a few questions, did you have some trouble remembering things?
Yeah, I did.
Okay. Now, is that normal?
Yeah, Mom's pretty forgetful, but she does fairly well.
I do good.
Yeah.
I do good.
You usually bathe yourself in the morning.
Mm-hmm.
We usually remind her.
So at baseline, then, you would say she was mildly forgetful?
Yes, she's pretty forgetful. She especially has trouble with names and dates.
Okay.
The grandkids'
I
names.
asked her.
Yeah.
I asked her what the names were, and she couldn't quite recall.
Yeah. You know, that reminds me, last time she was in the hospital, she got very confused. And the doctor said thought it could be a reaction to the medication. Do you remember that, Mom? Remember being a little confused?
No.
No.
Mrs. Bond.
What?
Mrs. Bond, let's leave your catheter alone.
Oh.
Okay. Oh, here, let's put
I
your
have to go
oxygen
to the
back
bank,
on.
dear.
Okay.
I've got to go. I
Okay,
have
let's
to go
sit
put
back.
my checks
Let's
in.
put your oxygen back on.
I have to go. No. No. I have
Thank
to
you
go.
very much.
I have to go to the bank. I got to put my checks in. It's the rule.
Okay.
It's the rule. I
Mrs.
got to
Bond,
go. I have to go.
You are at
now.
the hospital.
No.
You're safe. You're
I'm in the-
okay.
Am I sick?
Yes, you are.
Oh, no.
Here, let's put your glasses back on.
Oh, dear.
How's that? Can you see better?
Yes. Yeah.
Hi, Chris.
Hi,
Oh.
Mrs. Bonds.
Oh, who are you?
Mrs. Bonds.
Who are you?
My name is Chris.
Oh. I have
work
to go
with
to the
Ashley.
bank. I have to go to the
It's
bank.
okay. It's okay.
I got to put the checks in.
Mrs.
Yes, I got to
Bonds,
put my checks
Can you
in.
look at me for a minute?
Oh.
Okay.
Oh.
Okay. Listen,
Oh.
you're safe. Everything's okay, okay?
Oh.
Everything's okay. Your daughter was just here. Okay. She'll probably be back in a few minutes. Okay. We just need you to calm down and relax for a few minutes. You're safe here, okay?
Okay.
Mrs. Bonds, could you count backwards from 20 for me? From 20 to 1.
20, 19, 18. I have to let the dog out. I have to let the dog out.
Okay,
Oh.
Mrs. Bonds.
Okay.
Oh,
Can you please try to continue counting from 20 for me?
20, 19, 12, 12.
Ashley, I brought a few things to see if we could try to keep Mrs. Bonds safe while she's suddenly so confused, okay, because she's a fall risk.
Okay.
So what I did was I brought this reminder belt that we can put around her,
Okay.
and I also brought a walker so that we could put it in front of her in case she decides to get up when we're
Okay.
not here. So,
Okay, thank you so much for
okay,
your
maybe
help.
we can try to put that on.
Sure.
Bring it around the back. It's okay,
Mrs.
Mrs.
Bonds.
Bonds. We're just going to put this seat belt on you, okay?
Okay. There we go.
That's good. That's not too tight, is it?
No.
Okay. There we go. Okay. I want you to stay in the chair, all right?
What?
Don't try to get
What?
up.
What?
It's okay.
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 Mr. Fenn, 73 years old, has been admitted to the hospital with a broken hip.
Your surgery is scheduled for tomorrow in the morning, and our goal is to repair your hip as soon as possible because this helps to decrease your pain level and also it improves the healing process.
I see.
I want to ask you some questions because I want to assess your thinking ability because on this floor, and especially with what you've experienced with your hip, your fractured hip, we like to monitor a patient's thinking ability as often as we monitor a patient's blood pressure. So I'm going to ask you some quick questions. Okay?
Okay, they did in the emergency also.
Oh, they also asked you these questions earlier. Well, can you spell the word world for me backwards, please?
World backward. DLROW.
That's perfect. And how about, can you tell me what's today's date?
Today is Wednesday, September 12, 2007.
Perfect. And can you tell me how long or how many hours you've been in the hospital?
I think it's about 6 hours now.
That's perfect. It has been 6 hours. And when is your birthday?
I will be 74 on November 2nd.
That's all the questions I have for you right now. I do want to let you know, though, expect to be asked these questions frequently, okay? Because, like I said, it's very important that we monitor your thinking ability. Still assessing that you are in pain. I'm going to be right back, and I'm going to bring you your pain medicine.
Okay,
Do you need
thank
anything
you.
else while I'm back before I bring your pain medicine?
No, thank you. You have been very kind to me. Thank you.
Hi, Mr. Finn. Do you remember me? I'm your nurse. My name is Aria. Mr. Finn, are you okay?
I think so.
Do you know where you are, Mr. Finn?
I'm in my home, but
Well,
it looks strange.
Mr. Finn, actually, you're in the hospital right now. Do you remember why you're here?
Why?
You fell at home this morning and you broke your hip.
I did? Why I don't remember that? Am I going crazy?
No, Mr. Finn, don't get scared. It is very common for patients to get a little confused and sometimes for their brain to get a little fuzzy when they're new in the hospital. But you're okay. Mr. Finn, can you please tell me the date today? What day is today, sir?
I think I'm thirsty. Can
Well,
I get some drink?
Yeah, you have some water right here. I'm going to help you to drink some. Mr. Finn, the water's right here, sir. Mr. Finn, can you tell me what your birth date is, please? When were you born?
My birthday? I don't know.
I'm going to ask you a question that I asked you earlier. Can you please spell the word world backwards?
Word? What happened?
Well, nothing's wrong, Mr. Finn. Don't be scared. Can you please count from 20 down to 1?
Yes. 20, 19, 11, 15.
Delirium is a very common manifestation, especially during hospitalization for patients. Depending on the setting that the patient is in and the type of medical condition that they're admitted with, delirium can be as high as 80%. We see these very high percentiles in our patients that are in the intensive care units, medical and surgical ICUs. It's also a very common occurrence in our surgical patients, specifically post-orthopedic surgery and post-cardiac surgery. They seem to have an extremely high incidence of delirium. And then the remainder of hospitalized patients also have an ability to become delirious. So again, I think it depends on which population you're looking at, but across all populations it can be as high as 30 to 40%. There are many triggers that can cause delirium. When we think of triggers, we think of acute risk factors that are brand new to the patient's condition. I believe the most common risk factors that we see for causing delirium would be medications, infections, other acute illnesses that may be non-infectious, and then there are other factors that may also be contributing, such as Foley catheters and other types of equipment or environmental components that might be introduced. Delirium is usually multifactorial. It's rare that one factor is the sole cause for the delirium, although it can be. But most often we see several etiologies or causes that have been put on this patient that have caused the patient to tip into a delirium. In order to treat the delirium, you need to uncover the etiology or whatever it is underneath the delirium that's causing the delirium. That's why it's so important for nurses to not just look at the behavior and to go forward and ask the physician for a medication to calm an agitated patient. What they need to be looking at is what is causing this agitation so that we can get at that as well as actually managing the delirium. Delirium has to be seen as a medical emergency. Again, sometimes the cause is extremely urgent. Someone could be having an MI, somebody could be having a pulmonary embolism. We often see people deteriorate very rapidly once an acute delirium occurs and they end up needing intensive care treatment. Other deliriums may be more subtle in their presentation and their causes may be less urgent, such as a brewing infection, a medication reaction, but still they need to be addressed immediately because we need to find out what the cause is. We need to treat the cause as soon as possible so that we can decrease the severity and the prolongation of the delirious episode. There are different forms of delirium. There's hyperactive delirium, hypoactive delirium, and mixed delirium. Hyperactive delirium is very hard to miss as a clinician because these are the patients that will be swinging from the bed rails, yelling, screaming, accusing people of stealing things, trying to constantly get out of bed. So they display very agitated behaviors. Then we have hypoactive delirium, which, again, this is the most common type of delirium that is missed because the patient can be a very quiet patient. This patient can be the perfect patient. They could be sitting there and the nurse comes in and says, "So, how are you today?" "Fine." "Do you need anything?" "No." The issue is that they never speak because they don't know what's going on and they don't want anybody to know that. So often these patients are actually dismissed as normal mental status because no one has actually tested them to see what their attention span is. So this is where we miss these patients that are hypoactive. Also, then there's the obviously hypoactive patient who is having trouble staying awake while you're talking to them. They're falling asleep while they're eating their dinner. Again, these patients are often misdiagnosed because nurses will describe them as lethargic, but they won't make the connection that the lethargy is actually a change in mental status, is displaying disorganized thinking, inattention, and a change in level of consciousness, which are often consistent with a delirious condition. And then lastly, we have the patient that has what we call a mixed delirium, and these patients will fluctuate minute to minute, hour to hour, shift to shift between hyperactive states, hypoactive states, and normal mental status. There are certain individuals that are at high risk for developing delirium. First, we can talk about age, and the older a patient is, the higher their risk for delirium. A second high risk factor would be any sensory deficit, and that could include vision loss or hearing loss, which are the most common sensory losses, particularly in older adults. A third population of patients that are high risk for delirium is anyone that has a pre-existing dementia or a pre-existing cognitive impairment. These patients, delirium can be as high as 90% when they are hospitalized or when they become ill. And actually delirium is often the first sign of acute illness in a patient with a baseline cognitive impairment. A fourth risk factor for delirium would be having a history of delirium on previous admissions to the hospital or previous illnesses. We find that once a patient reacts in a delirious way to illness, it seems to repeat itself in future events. And a fifth category would be anyone that might be dependent on a substance, and that could be either alcohol or it could be other medications or drugs that specifically cannot be withdrawn abruptly. And sometimes patients are hospitalized and we inadvertently withdraw them from these substances either because we didn't know that they were dependent on them or because we feel that it's not in their best interest to take these substances. It's critical that clinicians begin to incorporate a delirium assessment into their normal patient care on a regular basis. And we recommend that this assessment be done every shift, particularly during a hospitalization. The reason it's so important is that we want to identify patients that have actually come into the hospital with a delirium, which is common because patients are acutely ill, and those that perhaps were not delirious on admission but go on to develop a delirium later on in the hospitalization. For example, the patient that we talked about today, Mrs. Bond, she's a perfect example of that. She was someone that came in with risk factors for developing delirium, specifically a pre-existing cognitive impairment, a visual deficit, and a hearing problem, and a history of delirium on a previous admission, and then went on to develop delirium throughout the day. Over time, and with several studies, it was found that there were 4 key elements that could be assessed that would give you an accurate diagnosis of delirium. And those are the 4 criteria that we see in our confusion assessment algorithm. And those would be, again, a change from the patient's baseline mental status or a fluctuation in mental status. Secondly, evidence of inattention. The third component is elements of disorganized thinking, and lastly, an altered level of consciousness. The first criteria that needs to be met in the CAM algorithm is to document a change in baseline mental status. Now, this is a challenge for hospital nurses because many times this is their first time encountering the patient. So they may not have the knowledge of what the patient's baseline is prior to hospitalization or even prior to the shift that they're taking care of them. So one of the challenges is to get that information, and there are a variety of ways to do that. One is to actually look in the document, the chart, to see if there is an admission or a documented baseline mental status from a reliable party. If that does not exist, other ways to get this information would be to try to solicit it from family or other parties that are familiar with the patient when they are not ill. Sometimes patients are not used to being asked routine questions to assess their mental status. So generally what we do with patients is we set the stage and say that we're going to ask you some questions just to see how your brain is working or how your thought processes are working at this time. We often preface it with the fact that many people actually have changes in their thinking abilities when they become ill. It's important for clinicians to check many sources to learn how to do the confusion assessment method. If you have someone at your clinical site that can help you to learn to use the tool, that can validate that you're using it correctly and to talk with about what to do with the information, that is ideal. Other supplemental resources would be the journal article that accompanies our video. A second source may be to check the website that is attached to the Institute for Geriatric Nursing. And a third would be to actually go to the website that has Sharon Inouye's Confusion Assessment Method Training Manual to get the subtle nuances of how to perform the tool and how to interpret the results. When we're vigilant in our screening and when clinicians are trained adequately to detect delirium and to administer a formal tool to help them to identify this often missed entity, we can see patients recovering from this condition more rapidly. There have been some studies that have shown that the quicker a delirium is recognized, the shorter the course and the shorter the intensity of the delirium.
One of the major issues when we talk about delirium in the older population is how common it is for us to not even recognize that delirium is there. And there's been, again, study after study that have demonstrated that as nurses, we miss more than 50%, sometimes 60% of delirium cases in the older adult. Given that delirium is an important signal, if you will, of a major medical condition, that means we are not recognizing what is going on acutely with the older adult, which means we are delaying necessary treatment, which then leads to that spiral of complications and downhill effects that can occur from delirium. Now let's talk about delirium on or superimposed on dementia. That gets even worse. Part of the difficulty is that there is some overlap of delirium and dementia symptoms. And nurses may not recognize then that a person with already a diagnosis of dementia, that those behavior changes are not necessarily due to the dementia alone, but are due to the delirium. One study that Dr. Fick had conducted was, again, interviewing both nurses and family members and physicians of hospitalized patients who had delirium superimposed on dementia. And what several of the nurses actually said was that once they knew that there was a diagnosis of dementia, such as Alzheimer's, they no longer then did any further assessment of the person's mental status or cognition, assuming that all the behavior that was then ensuing was due to the dementia itself. We know that delirium is much more apt to occur in patients with dementia by almost a 4 to 5-fold effect. Part of this may be due to the already neuropathophysiology that is occurring with people with dementia that make them even more susceptible to changes that occur with delirium. Again, it's not well understood or known, but it could certainly be because of the changes that have occurred with the dementia. For those people with dementia, this can be further insult to both their cognition as well as their physical function that may be the breaking point that they require institutionalization or can no longer live independently in the community. These are the patients who are more at risk for falls, for nosocomial infections, longer lengths of hospital stay, as well as institutionalization. With patients who have a known diagnosis of dementia, when you have a patient who is difficult to rouse, they're sleepy, they're somnolent, they're lethargic, you can't just assume that that's part of the dementia. We know that it isn't until the terminal stages or the final stages of dementia that people are so somnolent or difficult to rouse. Another behavior that nurses will sometimes misinterpret as being solely belonging to dementia is, it's an old term, but it's still sometimes used, sundowning syndrome. There are certain patients with dementia who, towards the evening hours, will become more restless, more agitated, and part of that is they've been up all day, they're tired, you have the changes with the lighting. Well, if we now have a patient who's actually showing the fluctuation that is cardinal with delirium, where they have waxing and waning of their symptoms, a nurse who is caring for a patient with dementia may assume that this is just sundowning syndrome and that it's not related truly to delirium. It is absolutely essential that nurses speak to the family caregivers or the long-term caregivers if they are from a nursing facility and identify what is that person's usual behavior. You cannot assume that what you are seeing is the person's typical behavior that they have from dementia.
So Ashley, that was a little bit stressful, huh?
Very. Thank you so much for coming in and helping me.
Oh, you're welcome.
I really appreciate it.
I'm glad we were able to calm her down a little bit.
Know.
Well, let's talk about it now.
Did you do the confusion assessment method
I
algorithm
did.
on her?
Yes, I
okay.
did.
Okay, well, why don't we walk through that and see if
Okay.
we can kind of figure out what's going on.
Okay.
So the first question that we need to answer when we're doing the CAM is the patient displaying an acute change in mental status from baseline, or is the patient displaying a fluctuation in her mental status? So do you think that Mrs. Bond met criteria,
Well,
number one?
I would say yeah. Even though she is, confused at baseline, it's still way different than
Right.
what she normally was. And the fluctuation, would that be like how she was kind of agitated, then by the end she was falling asleep?
Exactly.
Okay.
Right.
Then yeah, definitely.
Right. And also you could see the fluctuation from the first time you saw her to the second time that you
Right.
saw her.
Yeah.
So I think she definitely meets criteria number one.
Okay.
The second criteria for the algorithm is, did she display inattention?
And
Right.
she fell asleep when I was asking her a question.
Right, right.
So she was not paying attention to anything I was saying.
Right.
You
She
know,
was having trouble
couldn't-
focusing.
Yeah, she couldn't focus.
Right, right. And I noticed that you tried to get her to do a formal attentional test by asking her to count backwards, and she couldn't even comprehend what that was.
She thought it was the time or something.
Right. Sometimes when it's not so obvious, when you're doing a confusion assessment method algorithm on a patient, you do have to perform the actual test of attention. I'm curious, when you met her earlier today, did you do the attentional test on her?
Yes.
Okay.
And she was able to count backwards from 20 to 1.
Okay, perfect. So we have documented change in that as well. Okay.
Yep.
Now, the third criteria that we would have to assess is, does she display any elements of disorganized thinking? That can include problems, following conversation, expressing herself, speaking in a way that makes sense.
Well, I mean, yeah,
Okay.
she kept wanting to let her dog out, like you heard.
Right.
And, bring the checks to the bank, and, I mean, that's...
Right.
Is that what you mean by
That's
that?
that's perfect evidence of
Okay.
disorganized thinking.
Okay.
Now, because she has a dementia at baseline, many patients with dementia often meet criteria for disorganized thinking when they're not delirious. I'm curious, so earlier when you met with her, did she have trouble like with her memory or orientation to time and place?
Not so much orientation. She knew where she was, wasn't quite sure why.
Okay.
Like I had just said, it was more, dates, names.
Okay.
But she knew, I'm really not good at that. I'm
Yep.
not really good at names.
Okay.
But, she could say she was in the hospital, and she said, I must be sick.
Yep.
So she knew. It wasn't just like pulling it from space.
Right.
But
Did she know what year it was? I'm curious.
no.
Okay.
No. 1975,
Okay.
she thought.
And you said that the daughter said that that was her baseline. Okay.
Yeah.
So again, she met disorganized thinking criteria earlier in the day and also the second
Right.
time that we saw her, which is not unusual for patients with dementia.
Right.
And the fourth criteria that we need to look at is the altered level of consciousness. Do you think that she met criteria for altered level of consciousness?
Well, yeah. I mean, would that be because, like, her fluctuation in her personality?
Right, right. When you think of level of consciousness, you would rate them either, are they alert? And if they're
Yes.
not alert, then are they drowsy? Are they stuporous? Are they comatose? Or are they hyper alert? And just from what I observed in our interaction, that she displayed some evidence of a hyper alert state at the beginning when she was really agitated, and then when she started to doze off, she was quite drowsy.
Drowsy,
So
yeah.
I think for sure she met criteria 4.
So it'd be mixed, right?
Right. So for our assessment, exactly. For our assessment, she met criteria 1, criteria 2, criteria 3, and criteria 4. So she definitely meets criteria for delirium. Now, in order to meet criteria for delirium, you only have to meet criteria 1, 2, and either 3 or 4. She actually met all 4.
Okay.
And as you were just saying before, she displays what we would call a mixed delirium,
Oh,
meaning
okay.
she has some periods of hyper alertness and other periods of hypo alertness.
So then what's the difference between confusion and delirium?
Okay. Well, confusion is actually just a general term that people have used for many, many years. And what confusion means to one person could be totally different than another. So you can see it's a very nebulous term. So if I were to say to you, I think this patient is confused, you don't know if I'm saying that's because they're disoriented, they don't know where they are, they don't know the date. Maybe I'm saying they're confused because they can't remember what I just told them a couple of minutes ago. maybe they're displaying quote-unquote confusion because they're not making sense when I talk to them. So you can see what I'm getting at is that confusion is kind of a catch-all term, and what we try to do is we try to be more specific about what exactly this quote-unquote confused behavior is. Now, people with delirium have to meet the other 4 criteria. So in other words, you could have a person that is quote-unquote confused or forgetful or disoriented, but not be delirious, as Mrs. Bond, I believe, was this morning.
Right.
Okay, she may have been considered confused at your first encounter, but she wasn't delirious because she didn't have any problems with her attention span. She didn't have any change from her baseline mental status. Does that help?
Yep, definitely.
Okay.
Definitely.
So that's why we try to assess people for delirium, because delirium is an acute event, and sometimes it can be so acute that we need to take urgent measures in order to protect the patient.
Now, can anyone become delirious?
Absolutely. Again, the older the patient and other risk factors can definitely contribute. Why don't we walk through Mrs. Bond's risk factors and see if we can identify some of the things that might have put her at risk for delirium. There's actually 2 types of risk factors. One are called pre-existing or predisposing risk factors. These are things that a patient has that are part of their profile. For example, her age. Now, she's 77, is that right? So being 77 puts you at risk for being delirium because the older a patient is, the higher the risk for developing it. It's not a given that they're going to develop delirium, but it's definitely a risk factor. Now, she also has some sensory loss, is that right?
Yes.
Okay, what does she have?
I know she has macular degeneration.
Okay.
So her vision.
Okay, so that's, again, that's a predisposing risk factor because it's something that she has that is not a changeable or a treatable condition, and she's had that. Okay, so definitely if you can't see well.
Her hearing loss.
Right, okay, so you put those 2 together, and it's even harder for people to communicate or to maintain their orientation.
She does also have a history of vascular dementia.
Okay, so again, that's another predisposing risk factor. Because
that's a big one, right?
That's a huge one.
Okay.
Because people that have dementia are extremely high risk for developing delirium during the hospitalization. Now, what were some of her new onset risk factors? For example, things that are recent that have occurred to her that might put her at risk for delirium.
She didn't have her oxygen on.
Okay, right.
So she could be hypoxic.
Right.
The Foley, of course.
Okay.
She didn't have her glasses on.
Okay.
New environment.
Right. And then, of course, her pneumonia itself, the infection can cause delirium in older patients.
Infection,
Right. Now, she was up most of the night also.
She was in the emergency room all night.
Okay, so that could make anybody a little bit off. Right. I'm just curious, did we check her oxygen saturation at all today?
Yeah, well, originally at baseline it was about 96%.
Okay.
And then when we went in there, the aide reported back to me that it was down to 80. I believe she said 85%.
Oh, okay, all right.
So once we got the oxygen back on, we rechecked and it was back up to 93%, which is good. You know, we want to keep it at least 93%.
So hypoxemia definitely could have contributed. And just back to your point about Foley catheter, many people don't realize this, but just the presence of a Foley catheter can contribute to delirium. There's been many studies that have been done on this, and not only do Foleys actually cause urinary tract infections because of, again, an opportunity for organisms to enter, but just the presence of a Foley, even without causing a urinary tract infection, can cause delirium. So that's one of the reasons why we want to get rid of anything that we can or avoid those kind of treatments. Right. Now, what about her medication? Medication is commonly a reason for delirium. Do you know what she was on when she was admitted?
Yeah.
What her admission meds are?
Well, I mean, she was on Aricept at home.
Okay.
Which she's going to have to stay on.
Right, and that makes sense
dementia,
for her dementia. Yeah.
Here she was started on antibiotic for the obvious pneumonia.
Okay.
And then also she was on, I believe they started her on Pepsid.
Oh.
Which right there is a huge, huge risk.
And she got at least one dose of that already. So.
Yep.
that's definitely something we need to talk with
to the pharmacist about.
right, the pharmacist and the physician to see if they really want to continue that, because I think that that could be one of the factors that's contributing. Ashley has been working with Mrs. Bonds today, and so I'd like Ashley to tell us a little bit about how the day has gone so far.
Okay. Well, initially, when I met with Mrs. Bond, she, demonstrated some signs of forgetfulness, some periods of poor memory. She definitely had some difficulty remembering dates and names, especially. Even her 3 grandchildren, she could not remember the names. However, her daughter came in and expressed that this is her normal behavior. She is at baseline forgetful.
Mm-hmm.
So after we established that, I was then called in the room about an hour and a half later from the aide. Mrs. Bond was pulling at her Foley. Her oxygen had been off. Her glasses were off. Wasn't really sure where she was. Really needed some redirection, but I had a difficult time redirecting her.
Ashley and I discussed Mrs. Bonds after this incident, and we did decide that she does score positive for delirium according to the confusion assessment method. So based on that, we wanted to talk with the team members today about what possibly could be causing her delirium, and then to talk about how we're going to make sure that we keep her safe, nourished, hydrated, comfortable, and calm during the rest of her hospitalization so that she doesn't have any additional problems.
For this patient, I would suggest to the group that we should continue with the use of her antibiotics and repeat the chest x-ray in a couple of days. I would also suggest to the group that we titrate her oxygen to maintain an O2 saturation more than 92%, as hypoxemia has been shown to cloud the sensorium in a patient with delirium. I will also suggest to the group to discontinue the Foley catheter if there's no medical indication for it, as it is an indirect form of immobilization in a patient who is hospitalized. Now, I would also suggest that we review her medications, and I would defer to Kristen, our pharmacist.
Okay. Mrs. Bond came in on Aricept or donepezil, 10 milligrams a day. That was her only home med. That's for her Alzheimer's or dementia. She in-house has been on that, and also Rocephin or ceftriaxone 1 gram Q-day for her pneumonia. She's also on Pepcid or famotidine 10 milligrams IV twice a day. That is just a prophylaxis. Now, just looking at her short med list, I would suggest we continue the Aricept because we could do more harm than benefit by DCing that. And DCing it would actually contribute possibly to her delirium. As far as the Rocephin goes, that's not going to cause any problem with delirium. It's a good choice of antibiotic for her pneumonia. The Pepcid, however, has been known to cause delirium in older adults, especially ones with renal dysfunction. So I think we should discontinue it, especially since it's just for prophylaxis. And then just as a note for nursing and for you, I think we should avoid any meds with CNS side effects, potential side effects, such as opioids for pain or benzodiazepines for the delirium. That's not a good choice for this patient.
Let's discuss safety. She's at huge risk for falling because of this delirium.
Well, one of the number one things I know we can do is definitely keep her personal items within reach. If at all feasible, possibly move her closer to the nurse's station so we can keep a better eye on her. Mm-hmm. And if we need immediate intervention, we can get there quickly. She does, like you said, use a walker at home. It would definitely benefit us to keep the walker within reach, so that way if she does need to get up and we're not able to get in there quick enough, she has the walker available to help her ambulate.
Mm-hmm.
Also, if we are going to DC that Foley, try to toilet her every 2 hours at least, so that way we can. It's also a reminder to her that we're there. We're going to be here, and we're going to be here frequently to help kind of ease her mind.
You had already mentioned that they were using a self-release Velcro belt, which was a good choice, I think, because even if it's not going to totally keep her in the chair necessarily, it's a good reminder for her to call for help, and I think that's very successful intervention very often. The chair alarms that we use here on the unit are very good, and if we could get a family member maybe to put their voice onto the alarm, that would even be more reassuring for the patient to have a familiar voice reminding them to stay in their chair and give us a little extra time to get to the bed. The side rails, I'd go with 2 side rails at this point. 4 would be a restraint, and that I don't think would cause more harm than good. So I think 2 side rails would give that extra reminder for her to call, and her call bell would be more in reach. And then the ambulation piece, I think, is just so critical to encourage the aides to get the patient up anytime that they can, to walk her to the bathroom, to make sure she has those assistive devices and she's reminded to use them.
The other issue we need to deal with is treatment disruption. You know, she's at risk for pulling out her IV. Also, we already saw that she took off her oxygen cannula, so it's a little bit tricky sometimes to get the treatments in place and maintained during her delirium.
You know, we do have something we use. It's a skin sleeve. It's, you know, neutral color that we kind of place over the IV site to help patients who are a little bit delirious from pulling at their IV, to just try to disguise it a little bit.
Okay.
You know, it kind of gives them something else to pick at.
We can get that
Some
for
other
her.
diversional activities.
That will be good. And I know some patients like those too because it makes them feel warm.
Right. Oh, they do. Right.
Now, how about her eating and drinking? We know she's at risk for possible malnutrition and dehydration during this delirium episode.
Well, definitely. I mean, I think the number one thing to do is get her out of bed. Who at home sits in bed and eats?
Right.
You know, get her up, get her in the chair. Try to get her into the same routine she is at home.
The only other thing that I might mention, Ashley, is that we might want to get our volunteers involved. We're fortunate here at our hospital to have a fairly large number of people that donate time that would be able to come and sit with Mrs. Bond and keep her company and make her feel a little safer. I think the interaction is good for someone like that. And then maybe encourage family if they're able to bring in familiar items from home, either a pillow or a quilt or something like that, something that makes her feel safe. And then pictures, remembrances from home so that we have things that we can talk to her about, maybe pictures of family or grandchildren, because that always is a good thing to do. Other than that, it sounds like we've got most of the bases covered, I'd say. Doing a great job.
Pass it on to the other healthcare providers.
Great.
Okay. Do you think she'll be able to come home again?
Absolutely. I don't see any reason why she shouldn't. Again, depending on how long she's here and how much of a toll the pneumonia takes on her functional status, there's a chance that she may need to go to short-term rehabilitation for a while, for a week or two to get her strength back. But I think it's a little too early right now to determine if that's going to be necessary or not. But we're going to do everything we can to keep her mobile so that she doesn't lose any ground.
And I'll try and be here as much as I can, maybe
Excellent.
even during the day. And